You're about to hear something all new to the world of aesthetic medicine. Five of the country's most credentialed surgeons, each at the top of their specialty, having the honest conversations that shape exceptional results. This is where surgical expertise meets collaborative excellence. This is Aesthetic Authority.
So, Peter, we're talking about a topic that I think is really kind of very prevalent in our practice situations. We're talking today about GLP-1s and what we're seeing in the aesthetic world.
Right.
When did you first start noticing patients were taking this? I think it's a little different for you and me based on where we are.
And so the interesting thing about like the win part of it is, these medications have been around for a while, but the patients that we're seeing most in at least the body side of things are the patients that are actively using this for weight loss. And so these medications were meant for diabetes originally. Now they're hugely prevalent for weight loss. And it's the weight loss patients mainly that are coming into our practice. And the upswing of the medication, at least like Ozempic was the first big one, but now lots of other GLP-1s have taken off, started sort of like just post or during COVID, almost 2021, 2022 was the upswing. And so it takes a little bit for people to lose weight. So I think the increase in practice volume of these patients probably was delayed a couple of years. So it's really just been the last 2-3 years that I think patients have really been coming in for weight loss surgeries for me.
Yeah, I would agree. I feel like I remember seeing my first patients on Byetta, that were, probably pre-COVID, and then really it was post-COVID that we noticed a huge increase. The other thing too about this medication is it's really expanded in terms of the scope of how it's used, and I think that's only going to continue.
Right.
Where are patients in their journey with this medication? Let's just pick the average kind of weight loss patient that you might see. Where do they come see you? What are they inquiring about?
Yeah.
Tell me a little bit about that.
Right. So I see almost like 3 different buckets of patients that come in. And I think the most common is a patient that has been on this medication for a while, has lost a lot of weight, and is seeing the results of that. And so with weight loss, and again, this is for any means, and we saw this through weight loss surgery, but now especially for these medications, loose skin everywhere. And so everybody has the things that they worry most about. And for some people, it's their abdomen. For some people, it's their arms. For some people, it's their breasts. And everyone has their list of priorities. But the patient that's already lost a reasonable amount of weight and is seeing these changes is the most common one that comes in to see me for a surgical consultation. Now, there's another segment of patients that are on these medications, have started losing weight and just know more about, and they have looked into this. This has been their plan all along. They said, I weigh X amount. I want to get to X amount of pounds. I'm halfway there. What does surgery look like? And that's great because they're the forward-thinking patient. They're getting prepared and they're just coming in for more information. But what we have to talk to those patients about is, yes, these surgeries will likely be good for you, but now's not the time. And so that's a whole nother discussion that I think we'll be able to talk about. But the last set of patients is a set of patients that I think has been working on weight loss forever, right? For years and years and years, tried all the different diet fads over the decades, tried exercise, and just like 5-10 pounds maybe come off, but they just aren't hitting the number that they want, right? And these patients, like, they don't qualify for bariatric surgery. They're just interested in losing the additional 20-30 pounds, and but they haven't tried these medications yet. And now that they're becoming more and more prevalent, I think that's a patient category that's now migrating to these medications. And we kind of even talk about that in the consult. I say, if you're interested in these surgeries and you want to lose 30-40 more pounds, still now is not the right time to have these surgeries. So what can you do to help get you there? Because everything else hasn't been working. You can try one of these medications if you feel like it's right for you, if you qualify. So those are sort of the 3 buckets that I see.
Do you think with like the exposure that GLP-1s have gotten, kind of the aesthetic consequences that sometimes we see with this, do you think patients are still a little surprised when they experience it?
I think so.
Yeah.
For example, our practice, we show before and afters a lot. And you look at the like commercials, even they show like before and afters, but obviously these are people that are just shedding weight in clothes, right? You don't actually see what's happening underneath everything. And they usually have the numbers like, I lost 50 pounds on this medication. That's great. But you don't really understand what that's going to look like, one, for you, but just in general, even for the people you see on the screen until it really happens to you. And so, and it can be quite dramatic. And so I think we obviously see even more of the patients that have had the dramatic success with these medications because the effects are more dramatic. And so they're seeing this more. They're coming in to talk about it a lot more too.
Yeah, it reminds me when I started practice, one of my first patients was a bariatric surgery patient. We're kind of tail end of all that bariatric surgery.
Yeah.
And I remember them saying that they didn't realize that the face was going to be affected to the extent that it was.
Right. Yeah.
You know, and I think that is what we're seeing again with a lot of these GLP-1s from a facial plastics perspective. There's a lot in terms of Ozempic face, but I think it's very different when somebody actually experiences, when somebody really kind of notices a pretty dramatic shift in like how their skin lays, how it moves, the lines and the wrinkles, you know, just how the contours and the shadows are kind of sitting up. So I think it's always interesting to see, like, you know, even though our population is now just more and more well informed with everything that's out there, it's interesting to see how it affects everybody.
And what do you think about that, the Ozempic face, like talking about the facial aspect of this these medications?
You know, I'm a little bit like, I think we're learning so much about the medication, and you absolutely see, like with any rapid weight loss, which we saw with bariatric surgery patients, that there is a major shift in the volume of fat in the face and the body. Specifically in the face, you're seeing also changes in like skin, collagen, elastin. You are seeing changes in terms of like, we think even on a cellular level, when you think about fat, how it evolves and differentiates into a cell, that progenitor, that early stem cell, its signaling is a little bit different. How it affects fibroblasts, which are really important, and wound healing may be a little different. I think that's the thing that's really exciting, but also interesting and worrisome sometimes of these medications. I do think that we have seen a huge explosion of patients who have been on this medication. I was just kind of tallying in my head randomly. I felt like sometimes everybody who's been in my clinic has been on it, tried it. Now, in terms of the surgical patients, I think that, you know, it's less than that, but and of course depends on the day. But I just think that the proportion is absolutely undeniable that this is a huge subset of our patients.
Oh, definitely.
You know, in terms of like what they're seeking, it's different because I have some patients who are actually quite happy with the fullness of their face that's come down, but they have some gravity changes as some of that has deflated. And the problem with some of this, the speed of weight loss is that, you know, sometimes your tissues cannot change and adapt to like the shrinking framework really underneath there. So that means that people are coming in and all this feels like it drops dramatically. It affects different parts of the face differently, which I find very fascinating. And I think that, like, you know, there's just a huge uptick in patients who feel like they have stepped into this like new world where they have parts of their body and they feel like as good as ever, but their face really does not reflect that. And I think that some people expect that. Other patients find that really emotionally taxing. You know, like, oh my gosh, I think my weight is good. I feel pretty good. My energy's never been better. My health, you know, my doctor says I'm off my diabetes meds, whatever. But I look like my grandmother. Like, that's hard. It's really, really hard for patients.
Yeah. And do you find it being predictable, all these patients that you're seeing? Can you say, oh, this patient's been on this GLP-1 for a year and a half, I know what I'm going to have to do? I always tell patients that for any form of weight loss, diet and exercise, surgery, medications, we don't get to decide where the weight comes off of us, because some people like come in for breast surgery and they say, well, maybe like a reduction, maybe I won't have to after I lose weight, and you lose weight and it's all in their stomach and they still need the breast surgery. So we don't get to decide. Is it different in the face? Do you feel like you know what you're going to have to do?
Yes and no. So there's been some studies that have shown like comparing patients who have been on GLP-1s. They did kind of CT scans before and after. And what they found is that there is absolutely seems to be like a statistically significant reduction in the superficial midface. That's kind of what I'm seeing where you see this deflation. When you see that, you also kind of notice how it's affecting the periorbital area. And then a lot of jowling. I think that's a lot from descent, when this all falls, this all collects. So the pattern seems kind of consistent for me. Whether or not, what we do about that is a little bit different. So, for example, sometimes I feel like if we need to lift, we lift. If we've lost volume, we need to add volume.
Yeah.
So, but sometimes people, like I said, kind of like some of the angularity and the contour they've got. They don't feel as like rounded and puffy. So, like, we just kind of talk about that aesthetic goal and see what we can do to reach it.
And that's great. So it's still like patient directed because, like you said, everyone will see something different. They might like, oh, all of a sudden you see my cheekbones, and that's great.
Yeah.
And so you have to keep that versus, normally you might plump up with some fat grafting. So still a patient directed and sort of driven decision making for the surgery.
I think absolutely. And the extent in terms of which we're losing weight is vastly different for patients. Some people are losing 20, some people are losing pretty significant amounts of weight. So we just have to kind of see how that affects the area.
Makes sense. So for patients that are coming in, they've lost X amount of pounds, like what are the most common procedures that you do?
I think that addressing the skin laxity with that volume loss, the sagging skin is probably like number one. Facelifting has always been a really, I think, great quality procedure that gives beautiful results, lasting results. But I think that we are seeing patients come in. I think the age demographic also kind of plays into it because it's not just all 60, 70-year-olds that are getting this. And, facelifting really isn't just for that age demographic. So I think that lifting procedures, not just facelifting, I see a lot of like lower blepharoplasty kind of patients. I see a lot of patients interested in volume restoration, whether that comes in the form of fillers or whether that comes in the form of fat grafting. It's interesting. There's a little bit of like discussion about, is it good to take fat from another part of your body and add it, especially if there is like kind of this change in, those fat stem cells, should we be kind of replenishing it? It's just a discussion. It was something that I was just kind of coming across in my reading. But yeah, I think that, we just want to think about what's happening and how can we go back to kind of a very restored natural look. You cannot deny that the volume restoration is a big part of this. I think that one thing that's also interesting is that skin seems to be also something that patients are starting to notice. So what I mean by that is you've got like more lines, more wrinkles, more kind of dynamic shifts in collagen, shifts in the elastin. I think that like sometimes when you are surgically working with these tissues, they all honestly feel a little bit different,
right, definitely.
So I think that like those are all things that I think about. We're doing a lot of like multimodality approaches to that. And I think that has helped patients. It's interesting, too, that patients are thinking about that as they're going through this journey. So they're saying, like, hey, I'm noticing this. What should I do? What should I be thinking about in the future? What can I do now? I think those are all really good questions.
Yeah, makes sense. You mentioned the age demographics. Do you think that's shifted with these medications? Do you feel like you're seeing more younger patients because of this?
Yeah, I mean, I feel like in my practice, at least, I think that I think across the board, I think younger patients are seeking out aesthetic surgery. So I it's hard to say if it's just this, but I do think like, when I compare like a patient who is on a GLP-1 older versus younger, I do see some physiologic kind of differences there. And I do feel like there are some tissue quality differences there on the whole. I mean, that's not in every situation, but I think generally speaking, because we have typically more collagen in our skin. We have like a better kind of skin quality usually instead of going through like 4 or 5 decades where you have photo aging and UV damage and all the things that we occur. So I think that that's kind of that can't be kind of denied. Some people are really thinking about if you have collagen depletion, should there be this idea of collagen banking? I don't think there's any data that show that one is like this is going to be superior or you're going to somehow navigate around some of this stuff.
Right.
But I think that, just to be aware of that, just in the same way that we know GLP-1s affect nutrition, appetite,
Right.
intake, protein, all those sorts of things. And so I think that has given us a real opportunity for us to say, how can I make you with this condition, with these medications, better and more successful in the end? And so it's being a little bit more proactive.
Right, right. So in that sense, patients that come in and say, I'm thinking of starting this medication, how do I avoid surgery? What's your answer to them?
Oh, I think it's really tough.
Yeah.
Because if you're younger and you've got good skin tone and you don't carry a lot of weight in your face, sometimes maybe you can get away with it, especially if you're going really gradual.
Yeah.
I think you give your body a chance to kind of adapt and do these sorts of things that you can sort of I won't say offset, but maybe just mitigate some of that.
Mm-hmm.
I think it's really hard when you're losing the amount of weight. I think sometimes it's just the amount that is hard to kind of work around.
Definitely, that magnitude. And I think it's the same thing in the body world is if you're going to lose like 10, 15 pounds, you're not going to need a surgery after that. But if you're talking 50 plus pounds, then you're going to notice areas, no matter how gradual or whatever that weight loss was, you're going to notice areas that, you had fullness there. Without the fullness, you're way out black.
Yeah.
And sometimes you're okay with that and sometimes you're not.
Yeah.
And that's what it comes
Yeah, I think that's a really good question. Sometimes we feel a certain way before, and as you experience, it's a little different. You can go both ways. Sometimes it's highly emotionally taxing, and other times people are like, no, it's okay. Like this is kind of part of my journey. And so there's nothing wrong with that either.
For sure.
Yeah.
For sure. When patients have lost 50, 60, sometimes I've seen 160 pounds from either a combination of these medications alone. It is pretty predictable in the body where you're going to see this, at least where I can address them. And so I think the number one area that patients come in for, and this is male and female patients, is the abdomen. I think a lot of times that's where they first noticed the extra weight they were holding, whether it was true obesity or just pesky weight that wasn't going away with that and exercise. And so since that's what they notice, once it's gone, then they notice the loose skin because it's something they've been focusing on. So abdomen, I think, is number one. Number two can be usually something in the upper body. I think the arms are the most visible to a lot of people. Like during summer, everyone wants to wear short sleeves. And if you're not able to wear short sleeves, it's noticeable every single day. And so people feel like they have to hide their extra skin by wearing long sleeves all year round. And they don't want to do that. So I think the arms is the next most common area. For women, it usually manifests in the breasts too. So there's almost always a combination of laxity from the upper arm all the way along the lateral chest and into the breast tissue. It's like a very defined contiguous area of laxity that sometimes I have to address all at once. And so that
arms into the breast area, just sweep
one solid thing from elbow all the way across the middle of the chest. And it's something that I think is, once you have that weight loss, it almost is a contiguous aesthetic unit. Yes, most of the time I'm treating them separately, but in the massive weight loss patients, most of the time I have to treat them together because if you just do piecemeal, then it's going to be very noticeable. So it's something that I think that is a little bit different about this specific patient population, is having to kind of morph how you treat this upper body, both arms and chest or breast area. And then lastly, for me, typically is the thighs. And so most of the time it's the area, I always talk to patients about, if we're doing surgery, breaking up surgeries, just because it's a lot of surgery to do all at once. And I don't think it's safe to do all that at once. So we break it up from a healing perspective and all those sorts of things. But the thighs are always on people's list, but it's always the last thing on their list because, in even shorts, most of the time you're able to hide the loose skin that you have. But it's sometimes it's a functional thing. Like these patients are trying to live a healthier lifestyle, so they're trying to get back into exercise, and it just is hard to do that when you're carrying loose skin everywhere, and especially in the thighs. And so that's, I think, the last area. There are like some minor areas, sometimes the upper back or just the back in general. Once we've addressed everything else, then I always tell patients, once you make one thing better, you're going to start noticing other areas. And if you've lost that much weight, then there's going to be other areas that you think about. And so there's certainly a point that I say, enough's enough. But at the same time, there are areas that if this is like the upper back, for example, if this is an area that bothers you, there's a surgery we call it the bra line back lift that removes specifically excess skin in that area, and we hide incisions or right where the bra line would lie. So those are the main areas that we typically see.
I liked how you thought about aesthetic units. We think about that all the time in the face because everything's in very close proximity, but it's really interesting to hear how you talk about it with body and body contouring. Can you comment? It's kind of maybe a silly question, but you've had this massive weight loss. Do you liposuction these patients? Is it strictly lifting? Is there room for both? What are you doing?
I think the liposuction piece of it kind of depends. And the interesting thing is, in the non-weight loss population, if I'm doing abdominoplasty, for example, post-pregnancy, either rectus diastasis or just loose abdominal skin, almost always there's also a segment of a little bit of excess adipose tissue, fatty tissue. A lot of times we call it the iliac area, so lower back, love handle area. That's also a very pesky area that a lot of patients have difficulty losing if they're trying to do weight loss on their own. And with these medications, again, we don't get to choose where the weight comes off of, but sometimes that area is addressed too. So I think it becomes a little bit more individualized. Whereas I say for someone who hasn't had any level of weight loss for abdominoplasty, I'm probably doing liposuction as an adjunct to that procedure 95, 98% of the time.
Yeah.
For the weight loss patient, it's probably less than that. It's probably closer to 50, 60% of the time because they're really just deflated. Yeah. And sometimes, there's pesky areas that still bother them. So we try to do some liposuction to really tailor those. And compared to 500, 600 cc's of fat that I'm able to get off a person that hasn't had any level of weight loss, it's 200 cc's of fat. Because it looks bad when the skin's all loose, but then when you tighten the skin, there's not a whole lot of volume there.
I know, that's kind of how I feel with the face. Yeah. Just curious, when you talk about the abdomen and what you're seeing, is there a preferential loss between subcutaneous versus visceral fat? Do we know?
Not really. I think what I always tell patients that come in for a consult is if they have a visceral fat component, that's something obviously as a plastic surgeon I can't touch. So the subcutaneous fat is something that is very, it's prime for liposuction. And so if it's something that I can add on to a procedure to help with the outcome because you're carrying some persistent abdominal fat extra abdominally or subcutaneously, then that's something that we could do with surgery still. But some people have that visceral component and they just see a big belly and they think, oh, liposuction is going to help with that. And I try to assess their skin and my skin pinch is only a centimeter or two. It's all intra-abdominal. It's all around their intestines. So there's nothing I can do as a plastic surgeon to address that. But honestly, with the GLP-1 patients, that's not usually an issue because maybe there is some preferential, but it's kind of all over the body. That's mostly gone when I see these patients.
What about skin tightening?
Mm-hmm. So, that's the number one thing that we're just similar to the face. What we're doing with these surgical interventions for weight loss patients, skin tightening is the number one thing. And where we do it is just what we just have different names for that. So abdominoplasty for the abdomen, but even that is a little bit more nuanced. Yeah. So patients that have lost massive amounts of weight, so over 100 pounds generally, I always have to assess which dimensions they have skin laxity in. A lot of times it's just sort of this vertical dimension where it's hanging down. They have almost a pannus of tissue, but it's loose hanging tissue just down. This upper abdominal, sort of what we call supraumbilical area above the belly button. Yeah. It doesn't have too much loose skin, so we're able to just pull straight down with a regular abdominoplasty. A lot of times it's extended, so I talk to patients about different lengths of incisions, and the incision length is always something that's a scary discussion for patients, but I show them, where is the excess of your skin? I have to extend that incision to accommodate for that excess, because if I stop short of that to try to minimize your incision, you're going to have a dog ear there. You're going to have a big amount of tissue that you're not going to like afterwards. So this is why the incision has to be where it is. But then with larger weight loss, a lot of times there's now a horizontal component too. So I could pinch this upper abdominal skin and there's a ton of skin I could sort of bring together. And when that's the case, I feel that addressing two dimensions of the skin excess is necessary. And so that's when we do what's called a fleur-de-lis abdominoplasty. So it's two incisions. It's a vertical incision straight down the midline, and then the lower abdominal incision, same as it was for abdominoplasty. And that's more common in the weight loss. It's pretty much only happening in the weight loss patient patient population. And that's across the board, whether it's GLP-1 or any other form of weight loss. Regular sort of mommy makeover type patient, most of the time you're not going to need that because you don't have that horizontal excess. But for the amount of skin that we're trying to get off, because again, these patients, their goal is like, how much skin can you remove from me? And that's the maximum amount of skin that I can remove, both vertically and horizontally. From the next set of the upper body, the arms, the breast, it's almost always a brachioplasty, so an arm lift. And that incision, we could do a couple different ways. I think the most common way is keeping an incision sort of inside the arm. And for the weight loss patients, again, most of the time I have to address an additional area of excess skin that comes down their lateral chest. And they notice this because it hangs in their bra or even in their shirts for men. It's hanging either above or below. It's kind of getting in the way. It's adding, again, the appearance of weight when they've lost all the weight. The number's down, but they can't fit into smaller clothes because the skin's still there. And so if I just address the arms and left that there, no one's going to be happy. And so there's a extended incision that comes up through sort of the armpit of the axilla and down the side of the chest in order to address that as a whole unit. And now for women who have now breastosis or sagging of their breasts, that kind of is confluent with my incision for a mastopexy or breast lift. And so when a female patient comes in with, again, 100 plus pounds of weight loss, a lot of times I do an incision that goes from the elbow all the way up to the armpit and then down the chest and around the breast in order to address everything as one. And that's something I could safely do at one surgery in order to, again, make sure we're addressing this entire upper anterior body as one unit versus trying to do it piecemeal and then people being unhappy afterwards.
It's really looking with an aesthetic eye and saying, really, what is going to make this look right? Do you use any non-surgical intervention like energy treatments or things like that for skin tightening? Is there an opportunity there?
I use, so the skin tightening that we use in the operating room is something called Renuvion, which uses sort of it's called J plasma, heated helium plasma energy. So it's all these technologies use heat applied under the skin to try to afford some skin tightening. And there's been multiple iterations, and this is sort of the newest iteration of this technology. I use it almost always in a post-liposuction patient. So if I'm doing liposuction along with some of these procedures, for example, in the abdomen in specific areas, the way I talk to patients about this is the reason that there's been multiple different technologies is because none of them are perfect. We don't have like the silver bullet to address skin laxity. And if we did, then I'd be doing a lot less body contouring surgeries, but we don't. And so this is sort of the best thing that we have to try to add on to these surgeries. And so if I'm doing liposuction in any specific areas, mainly more so in the back, because in areas that I'm not addressing through excisional means, then I could add on this technology.
I feel like it's an adjunct. It doesn't replace surgery. I think that's what I found in the neck as well. It's interesting to see as new technologies come out, they are going to further expand what we're able to do. But right now, I maybe it's me being a surgeon, but I do think there is something that is just really foundationally solid about some of these surgeries that you just can't get with the energy treatments.
Definitely.
So you have a patient who has lost weight. They're noticing changes. They feel great. They come in bouncing into your office and they are ready for surgery. How do we decide when the right time is?
Yeah, definitely. So, I mean, this has happened whether it's, again, GLP-1s or diet and exercise. Everyone has that goal number in mind, and they're seeing the progress. They're seeing the pounds tick off on the scale, and they're excited. So the very first thing any patient that has any amount of weight loss, 10, 50, 100 pounds, comes to my office, I always say congratulations, because this is something that they've been working on for probably a very long time. And whether it's like new success or it's something that's, they've done a pound a month for years again, whichever one it is, it's an accomplishment for them. And so you have to acknowledge that. And then it's something that they're doing it not because they want to have surgery. They're doing it because they want to live a healthier life. And that, I think, is awesome. So I congratulate them on that. And then we have to talk about the nitty gritty. So almost always, and I've had a couple of patients that say, I never step on the scale, but I'm on one of these medications. And I think that's great too, because you're doing it because you want to feel healthy. But almost always people have a number in their mind. There's a goal weight. And a lot of times whoever's prescribing this medication helps them come to that. And I don't think as a surgeon, I am going to ever define what that number is, what the weight that they're looking for is, because I don't think that's my role. But I do know that when they have that number, I talk to them a lot about that number. So where are you now? We have everyone, unfortunately, have to get on the scale in the office with us, but where are you now compared to what that number is?
Mm-hmm.
Are you 5-10 pounds off? Great. Let's talk about surgery. I think at that point, we can at least tell you you're pretty much there. If you get there and you're happy, now we just have to figure out how that's going to maintain, and we'll talk about time frame there. And I think no matter what, we can have a surgical discussion. But if you're 50 pounds from that and you've already lost 50 pounds, still great. Congratulations. Here's what I'm seeing now, but that could potentially change a lot. So I don't want to necessarily say, let's sign you up for X, Y, and Z surgery when you might not need that, or you might need something completely different. So we could talk about the surgical discussion at any stage of this, but the time frame of that is going to be you're at your goal weight. And for me, and for body contouring in general, and this has been far before GLP-1 medications, has been with bariatric surgery or any form of weight loss, when you've been stable at your goal weight for at least 6 months.
I think so too.
And that I think is safe, because I always tell patients, for me, I want you to prove to yourself that this change that you've made, whether it's with medication, with diet and exercise, with surgery, is sustainable. And you could do it in a safe way, and you feel healthy about it, you feel good about it. And it's because some people get to their goal weight and they say, I'm still on this medication, I haven't backed off on the dose yet, or we went down to a maintenance dose and I'm still losing weight.
Yeah, I think you have to look at that. You have to look at, of course, like where they are in terms of actual pounds, but also the length that they've been on that. I look at also what is their dosage, how long they have been on maintenance. All these things come together for us to decide. There are some implications as well from a surgical standpoint, as we know that, its effect on appetite and the gastric motility, that affects how you do in surgery. And so, they are continuing to revise, when do we need to discontinue GLP-1s prior to surgery? I feel very differently about that than my anesthesia colleagues. And the reason being is the recent guidelines says you could potentially stop 24 hours before surgery and just take clears. But, I'm thinking about like nutrition. I'm thinking about like, where we are in terms of like, what we're eating, how we're eating. I will tell you, I feel like I've done this just a little under a decade, and I feel like I've seen more wound healing issues than I ever have. Now, is that from GLP-1 usage? I don't know if it's strictly the actual chemical GLP-1, or is it the fact that my patients have really been calorie restricted? Even my patients who are very aggressive and they tell me they are eating X amount of protein and they are doing strength training and they're doing all this stuff. I've just seen wound healing delays and later. Like it's one thing if like a wound, what we call dehisces, which is when an incision, sutures are out, it opens up again. But I'm seeing that more often and later, which doesn't really make sense to me. I feel like if they are reaching that protein intake requirement, I think there is something on the cellular level. And so that's why I was telling you earlier, how it affects fat cells and fibroblasts, and that's really interesting to me. And I think it's something that we all think about. We, of course, are thinking about all this, in terms of the preventative, what sutures we use, how we use them. I have probably like shifted in the past, 5 years so that I'm thinking more about like hyperbaric oxygen usage, even as like, which is commonly used for wound healing kind of patients. And how does that augment the healing and recovery process? So it's all these things that are really at play. And I think that we are just learning more and more about it.
Oh, definitely. What we know about these patients is and we've said this multiple times throughout, when you lose weight, you don't get to decide where you lose the weight from. And you might lose it just in one discrete area, but most people are losing it throughout their body. So patients come in and they have weight loss, saggy skin everywhere. It's not just the body for when they see me. It's not just the face for when they see you. So I think having the opportunity to be able to have more comprehensive care of a total weight loss patient, GLP-1 or whatever, in one place, I think has probably helped these patients a lot. So I've seen a couple of patients, and I think we had a patient that we shared recently that had some weight loss. I did an abdominoplasty on, and
I
then
think it was this week.
I noticed just probably 6 months later or something, they were in the operating room with you for a facelift. So it's something that I think is probably going to happen more and more.
Yeah.
And being able to offer that all in one place, I think, is very powerful.
Yeah.
And how we do that, I think we're going to have to sort of figure out, because again, it's going to be more and more frequent. So what do you think about time frame of these surgeries, for if you're doing a face surgery, if you want to do a body surgery soon thereafter? What do you think about, should one go first, or what do you think about that?
I think that's something that is just so common, just having these patients that we get to collaborate with from both kind of perspectives. The one thing is, I think it really is dictated by the patient. And the only reason I say that is sometimes patients will come in and they say, gosh, I'm going to come see you, but this is driving me crazy. Or they'll say, I can't look at myself anymore. I'm going to do this. And then I've got some plans with Dr. Krasniak, Dr. Malfi. So I think that there are ways we can navigate it. Now, there are some procedures that I do feel it is beneficial to maybe consider doing some body contouring procedures first. It may not be as the reason I was asking you about, whether and how you're using liposuction is sometimes when you're liposuctioning, you're inundating that tissue with lots of fluid, and there can be fluid shifts, which from a facial perspective, I don't really want in my surgeries. So I think that sometimes I want some of that to settle down. I think about if you are doing surgeries that require a patient to be laying prone or laying on their belly, I don't want, for example, a patient who I've done a lift and a cheek augmentation with implants and all that stuff laying on that relatively soon. So, so I think that I want to figure out what your surgical plan is, what mine is, what the patient's priority is, and then how do we kind of all work together? It's always in the best interest of the patient,
And for example, if I'm doing a combination of surgeries on a patient, if a patient has weight loss, they want their abdomen done, they want their arms done, they want their legs done, I'm always going to separate those surgeries. And I tell the patient 6 months between each of those surgeries. So I want time for healing, because as we've talked about, I mean, I could say, oh, you'll be healed in 4 weeks, 6 weeks, and then they have an issue, a delayed healing and dehiscence, and it spreads that out for another month or so. So no matter what, I think the vast majority of patients are going to be fully recovered from that surgery at 6 months. And so that's when I can next stage my next operation. And I think when patients are coming and they say, I'm having tummy done, but then I'm also on Dr. Lee's schedule for my face, what's the time frame there? I'm tend to tell them the same exact thing, because I still want this surgery to be completely healed, because all their body's energy, all their nutrition, everything is going into healing these long incisions, and they're going to need that same thing to recover from your surgery. So our view are no different if we're talking face and body versus if we're just doing different body surgeries.
Yeah, I think people don't realize, I mean, these are bigger surgeries where you're thinking about your body's caloric expenditure and energy and that diversion. I always tell patients, a lot of times we're taking patients who are really pretty healthy, but we're putting you through a physiologic stressor, so we have to account for that, and we don't want to do anything that really depletes. We want to build you up so that you heal great, so that this is something that you get to really enjoy quickly, and the recovery is very smooth as possible.
Elective surgeries, let's make them the most successful they could be to heal these.
I want it predictable, and that's from that standpoint.
Exactly. So this is still relatively young, and we're seeing more and more patients, but over the next 5-10 years, where do you think this is going?
So they're coming out with newer GLP-1s. They're coming out with medications that target more receptors. I think that's kind of shown that it's going to be sometimes more dramatic weight loss. I think you're going to see more applications of this, whether it is sleep apnea, metabolic diseases like fatty liver, where you're going to see it in addiction medicines. You're going to see more and more people, maybe not to the extent that we're seeing it in these kind of massive weight loss patients. You are seeing industries being changed. You're seeing the food and restaurant industries being changed by this. I think that's incredible, that this impact it's having. I think from an aesthetic standpoint, I think we want to understand what is physiologically happening, what our patients are experiencing, and to really try to find a way that we can meet their needs in a really safe manner, and see that ways that we can be more and more proactive. The muscle wasting is a big kind of concern for patients, but I think we're going to start seeing where patients are looking for medications that have less of that side effect. And so, it's just going to be very exciting for us to be able to kind of respond as a medical medical community, as an aesthetic kind of advisor for a lot of these patients, and to kind of continue to collaborate with these patients or with you on these patients,
Right.
for sure.
For sure. And then just figuring out the whole biology of this, I think,
And
like you said, is going to be huge. And I think that's going to happen in the next 5 or so years. And so figuring out what we need to be doing, if we've already been doing it, that's great. But if we have adjuncts to help these patients get through these surgeries, because there's going to be a higher volume of patients on these medications. And so there's going to be a higher volume of patients that are seeing the effects and wanting to have surgery to address this loose skin. And so making sure that we're doing the best that we can to handle these patients safely and getting them the best results possible.
yeah, I think the data will show what's working and what's not. Like, there's a lot of interest in, like, should we use biostimulatory molecules in the face as a preemptive sort of like preparation for GLP-1 usage? I don't know. I honestly don't know how significant that is. So I think as the data show us, what is beneficial and what's not, we'll be able to kind of advise and lead our patients more successfully.
Right.